Afternoon. Glad you all can join us. Those of you who are with us today, my name is Latrice Hughes, and I'm a health systems coordinator in the chronic disease division at DC Health. And again, if you could please take a moment and add your name and organization to the chat box so we'll know who is joining us today. I'm always excited for the opportunity for our partners to share what they've been working on. I, typically hear it during our one-on-one calls, but I'm glad that we are able to use this platform to share what we've been working on in the heart disease and hypertension space. So I'm looking forward to the facilitated discussions that will be led today by Mental Health DC and Family Medical Counseling Services as they discuss their Million Hearts intervention successes and challenges, and open the floor for some discussion around that. So I'll allow them to introduce themselves in just a moment, but we will start today with a quick update on from Health Management Associates on the initial results from our latest grantee survey. So I think I can pass it over to you, Mary Kate.
Yes, thanks, Latrice. Yeah, as a reminder, we're offering CME for this session. We didn't offer it for the last one because that was really a feedback session, but we are offering CME, and you know what that means. That means we have some learning objectives, and we also will be, if you want CME, you would need to complete an evaluation link that'll come out after this session. And that would come from Samantha DePaula from HMA. And so these are the presenters and facilitators for today. I'm going to start a little bit with the survey update, but you can see who you're about to hear from. And again, like we said, at the beginning of each of their sessions, we'll ask them to introduce themselves so that we know a little bit more about them. Go ahead, next slide. This is the agenda. You're kind of hearing about this already. Go ahead, Sam, next one. These are the learning objectives, again, required for CME, but also to expand upon what the agenda will be doing. So we'll want to make sure that you can define initial findings from the Million Hearts feedback survey, identify opportunities to improve programming, and apply lessons learned from other grantees. So I'll say it a little bit again later, but whenever we hear from other grantees, of course, what we're doing is we're hearing about what worked for them, what may have been a challenge. We're seeing ways that perhaps we can apply it in our own settings. Or share something that we've done that could help the grantees who are standing up here and sharing some of their challenges. Next slide, please. All right, so first we'll get into the update since last month's meeting. So you probably remember that last month's session was about grantee feedback on Million Hearts and on opportunities for future initiatives. So after the session, we sent out surveys for input, and we want to make sure to share the initial results. And so a big thanks to Samantha DePaula, who created the survey, and then also Christina on our team. I'm not sure if she could join today, but she really pulled together a lot of the results from the survey for the initial sharing that I'm about to do. So the goal of asking for grantee input is to better serve the district residents and the providers who care for them through continuous performance improvement. So we all are very aware of CQI and CPI. We do it every day. And we really wanted to elicit feedback to complement the metrics and the work plan reports and everything else that we know you're working on. We also, you probably saw through the survey that we wanted to hear about your experience. And then we want to be able to gather that to figure out innovative approaches to address the cardiovascular health initiative. That was the new potential funding initiative. And so there were questions in there about potential new initiatives. So next slide. So here's a summary of the results. So 6 of the 8 grantees responded. And I'll just tell you, this is a summary, but then we're actually going to go through each question so you can see some of the results. And again, like I said, we'll be sharing this afterwards. Latrice mentioned that we're recording this. But we also share a PDF of the slide deck afterwards, so you can see more of this if you want to. So 6 of the 8 grantees responded. Thank you very much. Overall, positive input. Very appreciative of the opportunity to provide the feedback. So I'm glad that we were able to have the session and the follow-up survey to have 2 additional ways to provide feedback. Overall, there's an appreciation of the flexibility allowed through the partnership. reporting and communication, and generally a great experience with Million Hearts, and they appreciate DC Health support, especially in alignment with other service areas. Some opportunities for improvement: data collection, some challenges overall with data collection, capacity issues, which I think it goes beyond data collection. I know we hear about workforce shortages across the board, varied ability to use data in daily practice. TA, that really relates to, related to a lot of different parts, monthly meetings, monthly Million Hearts Learning Collaborative meetings, individual grantee meetings, the website, other opportunities for TA. So TA overall included all of that, but a general request for a more streamlined approach and less administrative burden. Again, we can understand, given the limited capacity, that we all want to streamline and leverage meetings as well as possible. And then there's ongoing barriers to implementation and sustainability. That were some concerns that were raised. So next we'll get into kind of the play-by-play for each of the questions. So I'll go relatively quickly, but I wanted to at least show you how it broke down a little bit. So you probably remember that there were different sections rating the partnership, and then you'll see the rest of the sections, but within each section, there was a scale that you could respond to about each of the questions, ranging from needs development to well-developed. But then there was an opportunity for comments as well. So in general, you can see for rating the partnership, the relationship, maximizing the partnership's value, partnership communication, it all ranked pretty high, especially partnership communication. So you can see some of the comments here. I'll just touch on it a little bit. Appreciates the collaboration with DC Health to support the goal of improving health outcomes for their patients. TA from DC Health and HMA, so that's great. CIPs, flexibility, that again was pulled into some of the summary bullets before. And then communication, consistent, respectful, responsive, and you can see some of the ideas there. Next slide. And just so you know, if you have any thoughts or comments, you can put them into the chat box, but we'll have a little time after I run through these to also share your thoughts about what you're seeing. Rating the project: internal buy-in, securing revenue, and service alignment. And so internal buy-in and service alignment scored higher. Securing revenue, I'm not surprised that there's always a little bit more challenges and concerns there. There's varied accounts of funding sustainability. Some have organizational funding committed. Some rely only on the on the grant funds. So it makes sense. Revenue is always a challenge, especially for ongoing sustainability. Next slide. The next one was service delivery. I think it has the same question. So service delivery capacity, workflow processes, and patient and community engagement. This varied a little bit more. If you can see at the top when a question had some answers where it was needs development and somewhat needs development, we marked it as red. Service delivery capacity, we even pulled that out into the summary bullets. But respondents have just asked for more community health workers, more support for teams that are stretched thin, staff turnover, recruitment remain challenges. But sites are still looking for ways to grow the program. So that's encouraging, and that's a valiant effort of all of you considering the limited capacity. Next slide. This is rating the project again. Data collection, generally pretty high, even though there were some challenges reported. And data usage also ranked pretty developed, but again, data we think is something that's kind of pulled out to be able to focus on in the future. Next slide. This is about TA. So I summarized these 4 bullets kind of in the overall TA recommendations moving forward. Of all of them, the Living Well DC website was ranked the lowest, but still neutral somewhat or very useful. Oh, that's right. For these, I should remind you that while the other scales were not as developed to developed, this scale was a little different. It was either not at all or very useful. So opportunities for improvement with the Living Well DC website. And then if you look for the bottom, request for streamlined TA for fewer team meetings to avoid blocking clinical hours, monthly CIP, pose an administrative burden. So we're sharing this with you just so you're also hearing the input that we received. Next slide. This is about the administrative processes, reporting and payment. Again, most of it ranked high or scored pretty well, but the ones that stick out is how helpful was DC Health's reporting process as an opportunity to learn, how useful was the Million Hearts data reported back to your site, and then how well did the grant offset costs associated with the work. I feel like I mentioned that a little bit before already in the summary, but you can see that the administrative burden is an ongoing concern, and it's noted that we want to continue to streamline reporting, report back, meetings, and opportunities for TA. All right, next slide. I think the last one. Oh, and this was the bit about additional funding opportunities. So you could see that for the majority, oh, this one should be red. It wasn't red, but you know, for the most part, many of the grantees are interested in ongoing funding opportunities. There's obviously a concern about being able to have the capacity to be able to accommodate more grant requirements, more reporting requirements. So that's really the only concern there. And that's the summary. Most grantees reported interest in new opportunities, and as we mentioned before, great appreciation for working in collaboration with DC Health. It's just the workload, which we totally understand. Right, next slide. I think the last one, here we go. Yes, and this was also already summarized in the initial bullet, but I'm glad that folks chimed in with some additional feedback at the end. So I'll stop here. And before I open it up for any questions, Latrice, did you have anything to share about this? Any next steps with this input?
No, I mean, I've you know, shared my thank yous for the input. It was really helpful, especially as we are moving towards getting together our strategies for the next cooperative agreement over the next 5 years. We definitely took into consideration all of the feedback that we had, the good and the bad. So I'm glad that you all were able to openly share with us. And again, we're still open to hearing more feedback, especially for those grantees who have not quite completed the survey yet. There's still time to share some of your feedback, and thank you.
Great. Any comments from anyone on the line? Is this what you thought? Is this not what you thought? Any additions? I'm going to look at the chat. I think I just see introductions, but any thoughts?
Hi, this is Bradley with Unity Healthcare. I was just wondering if this if the data would be shared with all of us.
So we are sharing this slide deck with the results.
Perfect. Thank you.
Okay, yes, it'll be after the session. I think it's usually by early next week. We share a recording and we share a PDF of the slide deck. I think it's also posted on the Living Well DC website, so it'll be there as well.
Yes.
Mm-hmm. Okay. Well, if you think of something and you want to share it even after this, you can reach out and let us know. And as Latrice mentioned, there were 2 grantees that did not complete the survey. We can reach out and offer that opportunity to you if you want to add to this. All right, so let's move to the next part of the session. So now we're going to hear from representatives from 2 of the Million Hearts grantees. We'll have some time for presentation and some time for Q&A. As I mentioned before, as you're hearing from your partner grantees, please look and listen for interventions that might be helpful in your setting. Feel free to ask questions, post comments in the chat. We will watch for all your comments in the chat and pause where we can. And if you have suggestions, I'm sure that the presenters would love to hear those as well, because as we know, we're with a group of QI folks. So a lot of us are interested in improvement and ideas for improvement. Let's stick right here for a second. So next I'm going to hand it over to Miss Belusu. I know that some folks call her. Can you come off mute and say hello and the floor?
Hello, good morning.
Hi,
Sorry,
thank
good
you.
afternoon. It's 2, I guess. Okay. Good afternoon, everyone. My name is Aishwarya Bolusu. I am the manager of healthcare data analytics at Metro Health. I have been with Metro for almost 3.5 years now. And today I'm here to talk a little bit about the strategies we have at Metro Health to improve our productivity, patient experience, and a little bit into how we use our data and the quality of our data to provide high value healthcare to our patients. And I'm hoping that we all have something to learn from here and also open to feedback or any suggestions that you guys would have for us. Can we go to the next slide, please? So one of the things that we do is with our team, and especially our practice and practice managers and the office administrators, is organize MCO days, where we have partnerships with AmeriHealth, Caritas, MedStar, AmeriGroup. So I know like they collaborated into, like they merged into 1 or 2 groups. So what we do is we host like MCO days 1 to 2 times a month, where we open the schedule for the specific MCO patients who are prioritized for their office visits, but then we also keep some slots open for like, urgent visits or emergencies that patients want to come in for. So the process is like we receive a list of our patients from the MCOs that are due for their annual physical exams or who have like gaps in care, like uncontrolled HbA1c, and also a specific list for people who are chronic no-shows. And then our care team, our patient care coordinator, and our front desk, and also medical assistants, what they try to do is help us schedule these patients with the priority of like from the most required to tapering it down by the risk scores, and then make sure that we have these patients scheduled within that specific day so that we let them know like, hey, today is MedStar MCO day. Like, would you like to schedule a physical with us because you've been due for one? So it helps us to track and close the gaps in care, especially for patients with underlying chronic conditions. And data-wise, the platforms that we use to do this are like right now we use Navinet and CRISP DC to monitor these. Can we go to the next slide, please? And coming to the data part, what we do, so we monitor our clinical measures every month, and then we also monitor the gaps in care. So what we do is the data team tracks and reports all of our clinical quality measures monthly. So what I do is I run a clinical quality dashboard that we'll go over in a little bit, which has 24 of our clinical measures that we monitor on a monthly basis. And I report it to our clinical team so that all of our medical assistants, patient care coordinators, and all our physicians, including our medical director, are part of our internal clinical team so that they know how they are doing on the measures, and if there's like physician teams, how the teams are doing on the measures. And then once this meeting is done, the following week, we meet with our clinical quality committee, which comprises of a little bit of our board members and also our executive team. And we present the same findings to them, and then we get feedback or comments from our clinical quality committee on what they would like to see. And like there would be a little strategy session about that. And then towards the end of the month, we present the same to the Metro Health Board of Directors. And this is a monthly process. So we do it on like every second Tuesday would be the clinical quality meeting. I'm sorry, the internal meeting. And then second Friday would be the clinical quality committee meeting. And then the 4th Tuesday would be the Board of Directors. We would all go over especially coming to the medical report, we definitely would discuss all these measures and look for input from all the members of our team. Additionally, what we also do along with the clinical quality dashboard is we generate a gaps in care report so that let's say 60% of our patients have HbA1c less than 8. What we want to look at those 40% who do not have it in control, and what is stopping them from getting, like coming into the clinic and get them monitored. Like, that's where we want to look into the gaps in care and, why this patient is not being able to access care. If it's a transportation issue or like an insurance issue, then we put them on the sliding fee scale and make sure that they receive the care for it. So the cycle for this is we generate the gaps in care report every month, and then we also give it to our clinical team after the internal clinical meeting. All the clinical team, especially the medical assistants, including the front desk receptionists, receive this list where they go and call these patients personally and talk to them and see what's stopping them or what are the barriers to care over here. And then before that, the individual chart review is performed mostly by our patient care coordinator. And then, internally they generate a TE or an appointment follow-up that would go to the front desk where they talk to the patients and then schedule the patient and see so that we can get them on the schedule. And if the patient makes an appointment, then we get them into the lab, get the lab work done, or if they're due a physical, we get that done so that we can close these gaps and improve the quality of our clinical measures. Can we go to the next slide, please? So one of the things that we also tried to explore while generating the gaps in care is what causes the gaps in care measures. And then we came up with a systems thinking model, which shows what are the potential paths to gaps in care for our patients, especially for those who need cancer screening or chronic condition follow-up appointments, because we also want to understand how these are created so that we can address them. And some are the systems thinking model that we developed focused on why we have gaps in care. One of the major things is patients having distrust in healthcare providers, which comes from societal bias. And then if it's patients who are missing appointments, then a lot of it is because no access to transportation or they're unable to receive any reminders. So let's say we are saying hey, we are sending them weekly reminders, but they're not receiving it. And one of the problems is there is no consistent phone or email that is used by the patient. So we probably do not have an updated number or an email to reach the patient. And not necessarily all of our patients have emails. And then a lot of times there's also unstable housing. So even if they're sending mails, it's not reaching them because they were probably in a temporary housing at the time. And then, they've transferred into a different housing situation or have become homeless. And one of the most common thing for missing an appointment is the fear of invasive procedures, especially colonoscopies are one of the invasive procedures that people would not want to get. So what we tried to focus on is educating patients on there's Cologuard, so it doesn't, with respect to colonoscopy, that's the one thing that we wanted to talk about. And then another reason for gaps in care has also been recorded as low health prioritization, especially for the younger generation. And also a lot of people, it's more they have very stressful jobs and taxing careers, so they don't have time to go see the doctor, or they don't have time to focus on themselves and do self-care, which can also be caused because not just because of work stress, but also because of, again, unstable housing, low access to education, financial stress, which is caused because of low income, which again, this is something that we can address by putting them on the sliding fee scale because we are an FQ Etsy, and that is a opportunity. That's something we can offer to our patients. And the last one that we added to as why they have gaps in care is low perceived risk, because people don't understand sometimes why should I get this done? I just came in for a back pain and you're asking me to get a mammogram and a colonoscopy. I'm not happy with you. And we do see these comments on the patient satisfaction survey. So sometimes it's just the point of health literacy, why we need patients to, get these stuff done, as to talk to them and educate them on the importance of cancer screening or chronic conditions. And if they have underlying conditions, why do you need to follow up, or why do you need to have regular checkups and things like that? Could we go to the next slide, please?
Yeah, I'm just going to ask one follow-up question.
Absolutely.
So Latrice actually put it in the chat, but I mean, I think having the right contact information is always a challenge for for patients. But Latrice was asking specifically about wrong contact or outdated or wrong contact information in the referral list provided by MCOs.
So one of the things is when we get the list from MCOs, because we definitely have them in our system. So we go by we cross-check the contact information. If something has been updated in our system, if there's a discrepancy on the number that's provided from the MCOs and the number that we have, and then we try both those. But sometimes there's nothing or there's no response on either of them. That's where we run into challenges. And at least in the last year, one of the things that has helped us is because Metro Health now has like a men's shelter location, at least a little bit of our population, we have seen that some of our patients that we used to see at our main site have been directed to the men's shelter. Those who've been facing housing challenges, like, hey, we have a location in the site shelter, so that, so that at least a little bit of, I'm not saying it has solved the problem, but it's something that we saw helped improve our measures pertaining to that population. Yeah, so we did develop the systems thinking model based on from the focus of the patient, because we wanted to think from the patient's perspective and see what could be stopping them from, getting the care that they deserve or they need. So based on the problems or the issues, the concerns that we identified, what we were trying to do is, let's say, low perceived risk, the population with the low perceived risk who don't understand the require or why they need to get their colonoscopies or cancer screenings done. We focus on health literacy. So we have support groups and health groups that are organized by our case managers and also our patient care coordinator, where we talk to our patients on, hey, the importance of why we want. It's basic health education that we try to do through Zoom and virtual meetings. And we actually recently established a relationship with Amwell, where we are also trying to talk to people on diabetes education. Right now, we are just focused on diabetes, but in the future, we were going to increase it into hypertension education. So also targeting the people on diagnosed with hypertension on why it's important, and health literacy stuff of, aspect of why people need to focus on self-care. And if it comes to missing appointments, then we try to understand, we did a no-show survey to a lot of patients. We sent out, we got a list of chronic no-show patients, and we sent out a survey and asked the reason, what's the reason they could not make their appointment. And if it's insurance or a access, we offer Uber rides to our patients so that they have access to the clinics. And then if it's an insurance issue, then we make sure that we can put them on the sliding fee scale. So yes, we designed the systems thinking model based on the patient perspective, but the reason we did that is to come up with strategies that as an organization that we can try to, address these concerns. I hope that answered the question.
Yeah, thank you.
Thank you. So the next couple of slides are just illustrations of how our dashboards look like when we present it to our internal committee and the clinical quality committee. So this is, I think, the data from February. So we have 3 months data after this. So this is basically our trends in each of these measures that we monitor. We do a trends for 3 months because we want to see how we have been doing in the last 3 months. But then we also have a ongoing trending measures by individual measures that goes to individual physician teams. Can we go to the next slide, please? And this is our clinical quality dashboard that we recently implemented. So we had the dashboard for a very long time, but the color coding of it is something that we wanted to do for the ease of understanding. So if something is red in color, then it's a decrease in the measure compared to the last month. And if something is in green, then it's an improvement in the measure compared to the last month. And if it's yellow, then there's no significant increase or decrease. This was something that we did for our clinical quality committee because they wanted to get an understanding of how we are looking at how many greens, how many reds. And our goal is to stay in the yellow but preferably be in the green zone and reduce the number of red zones. And if they have stars next to their number, like the measure 4, 5, 17, 19, and 20, then we are, excuse me, then we are past the goal for these measures, which means we have to stay there or we have to be consistently focused on doing what we have been doing. So this is just for like ease of the visual presentation that we did. Just for our clinical quality committee. But this is basically what our dashboard looks like that we present every month. And we also focus on like what percentage difference has been noted, especially when it's in red. Can we go to the next slide, please? And one of the things that we do that I wanted to talk about, like on how we focus on health literacy and health education, is every month we send out newsletters to all of our patient base, and we have a specific section. Especially during the pandemic, we had a specific section on COVID-19. We started the section of COVID-19 during the last 2 years, where it focuses on the updates of COVID-19 for that month. Like for a while, we did promotions on COVID-19 vaccinations. So there was updates on that, but also like back to school vaccinations. And whenever the boosters were out, we wanted to let our patients know like, hey, we are offering boosters. And more than that, it was also, and all of this, the COVID-19 information was pulled only from CDC, but we had information on what's going on around the world. How are the trends? How are we doing with respect to the with respect to the cases and the reporting and the rates of that. And also because we also have a high majority of HIV and chronic condition population, how COVID-19 affects these people and what's the importance of like getting vaccinated or staying safe and practicing social distancing for these individuals. And we actually also did a study on COVID-19 vaccine acceptance in people with underlying conditions, which got published earlier this month. Other than that, so in the monthly newsletters, yeah, so we do definitely, I still continue to do that we have a COVID-19 section on it. Other than that, we have our outreach team who has like regular health education, not just virtual sessions, but also like we have health education pamphlets, let's say, a lot of them even at our men's shelter, where patients can just like pick one, read it, and what is the importance? Why do we need people to get tested? Not just HIV positive, but also for high-risk negative populations, especially. Right. And then under our Ryan-White grant, we have online psychosocial support groups. We started these, I think they were in place like years ago, but we switched into a virtual mode during the pandemic until, I want to say, we still have the option. They are hybrid right now. Like if you want to join it through a Zoom call, absolutely yes. But we also have on-site and venue-based support groups for patients who would like to, just meet in person and talk to our case managers. Another thing that we use is eClinical Works. Definitely has a lot of health education modules. That is one of the things our patient care coordinators use to provide health education pamphlets and also sit and talk to our patients about the health literacy aspect of the chronic conditions most of our patients face. And then we also have like on-site health education, obviously. That is also one of the things our patient care coordinators and also our medical assistants do when the patient is waiting. And we do this based on the risk scoring of our patient. Can we go to the next slide, please? So other than that, I think the last point that we wanted to talk about is patient engagement and communication. So we use we use a few different platforms to communicate with our patients. The majority of it being eClinical Works, where we definitely send out text messages and emails through the messenger and to all the web-enabled patients, and making sure they have all important updates and all the clinical information. Obviously, the PHI is concealed in that. And then to maintain and also to improve what we do and make sure that we're providing high-value healthcare, we do post-visit patient satisfaction surveys. And these were initially launched as anonymous because we wanted honest opinions. And then now it's still anonymous, but we have an option for the patient to provide their name and contact in case they want us to call them back and make sure that their complaint in some cases or concerns are addressed. But this is optional. So if they answer the question and choose to leave the name and the contact blank, we still get the survey, we still get the response. But if they want to, like, hey, this is my name, you call me so that I want to talk to you about it, instead of patients calling our front desk or talking, to share their concern, we just had this one in place so that they reach out to us. And we do get a lot of patients putting their names in and their phone numbers in so that we can call them back. We also have on-site and also online support groups where we try to talk to patient concerns. We actually also organized a focus group on understanding like what we can do better. And this was a community-based focus group where when patients when we had a food bank, patients came over and we wanted to talk to them about like, what can we do better and why do they think we need to improve in these areas, so that we had them talk to our case managers, who in turn reported that to our admin and executive team, and so that we can incorporate those thoughts into our strategies to provide better care to our patients. I think that is all I have for today. If you have any other questions and comments, and I think, so I would also like to know, like, how do you, any of you guys have plans with, like, do you also work with MCOs, or what else, that if you have any suggestions on how we can track our gaps better and close them better, then we would absolutely love to hear from you. And if there's any other data platforms or data tools that you use through or outside of ECW that would help us engage with our patients in a much better manner, I would love to hear that from you guys.
Yeah, thank you so much. I know there's so much to learn from what you're doing and from what others are doing. So you're hearing some of the thoughts. You heard the MCO days. You heard about the whole process that they have to identify gaps, but which I'm glad we've already had some questions about that, and you've seen some of their data metrics and communications. So just in the interest of time, and we need to keep moving, but I would recommend that if you have thoughts, you can share them directly with Ms. Belusu, or you can share with us and we'll connect you. We have her contact information in here. But I want to go ahead and go to the next slide and allow our next speaker to go. There's her contact information. And yes, we will be sharing the slides again as a reminder, because I know some of the information is a little smaller, but we still wanted to be able to show the richness of the dashboard and all of the different elements that she's looking at, that Metro Health's looking at. But next, I'm happy to have Mr. Nwosu, a family nurse practitioner from Family and Medical Counseling Service, present on some of their initiatives. Hello, are you ready?
Hello, good afternoon, everyone. How are you? I hope everyone is getting some rest this afternoon. My name is Nwosu, like Mary said. I'm a family nurse practitioner, Family and Medical Counseling Service, Inc. here in DC. I've been at Family Medical Counseling Service, Inc., also known as FMCS, for over 7 years. I'm also involved in our Million Hearts subcommittee, so where we focus on our patients with high blood pressure, hypertension, and diabetes, and coming up with plans and ways to have them well controlled, whether on treatment or with lifestyle management. Next slide, please. So the goal of this discussion is to, discuss about interventions, successes, and challenges to support our patient engagement in management of diabetes and hypertension, and also to share this information with other healthcare organizations to improve health outcome of patients with diabetes and hypertension. Next slide, please. So what are the interventions we're setting for hypertension in our clinic? First of all, we set up an agency-wide goal, blood pressure goal of less than 140/90 across the board. So every provider knows that this is the target for our patients. Of course, sometimes we come with patient-specific, depending on their medical issues. But on average, or in general, the goal is to get to 140/90, less than 140/90 blood pressure reading. So what we've done is develop accurate blood pressure measuring protocol and management procedures, which we see on the next slide, a diagram. What that basically is doing is to have a coordinated way of checking blood pressures and management with our patients. So one of the things we've done in that blood pressure protocol is to have a special blood pressure chairs in each exam room for to help measure accurate blood pressure. This is a chair that has an armrest, a footrest as well, to make sure that for our patients, they have their arm resting on above heart level, at the same time their foot resting without dangling in the air. That will enable them to get accurate blood pressure. We also develop a barrier checklist in the EMR where the medical assistant is going to ask the patients about the cause for their blood pressure being high, try to know if they smoke cigarettes, if there's any, if they walked fast or ran through the appointment, if there's any stress issue going on in their life. So those are the things that they put in the checklist, so that provider will see this before going into the room and know how to approach the patient. We also have what we call heart magnets. It's a little piece of heart-shaped magnet that the medical assistant will place on each door if the patient blood pressure is 140/90 or above. So that will immediately prompt the provider to know that the patient he or she is walking in to go see has a very high blood pressure, and that way can enter the room calmly and know how to approach the patient. We also have in this situation when the blood pressure is elevated above the goal, the provider knows that when he or she goes into the room, the person is going to recheck that blood pressure again, which will be the third time, because the MA will have repeated it 2 times before making it available for provider. So the provider will decide to do either manual or, do other method to try to calm the patients. One of the things we do, conduct a brief exercise, deep breathing exercise for patients to have them relax, have them empty their bladder if they haven't done that. Also have them rest a little bit before going in there. So that helps to bring this blood pressure down. Now, and that intervention we've done is scheduling follow-up appointment for patients with blood pressure above goal to come back within 2 to 4 months. Now, when scheduling this appointment, sometimes it could be the patient seeing the provider one-on-one on that follow-up appointment, or we schedule them what we call the medtech schedule. So this is where they come in, they're only going to see the medical assistant or the nurse who will recheck their blood pressure. If it's good, they're allowed to go home. If it's not, and the provider is prompted to speak with the patient to see what is going on at that point. We also, do our best to provide blood pressure machines for patients to do at-home self-monitoring. And we know about the white coat syndrome, where some patients, whenever they're coming to the clinic, their blood pressure is always high, but when they're doing it at home, it's normal because they're in a relaxed environment. They don't have the anxiety of, what is going to happen when they come to the clinic. So by them doing it at home, we'll have them, create a log of this blood pressure at home, so that when they come in, we'll compare it to what it is in the clinic and be able to provide a better management to the patients. Another thing we do for intervention is we've tried everything for the patient where it's not being controlled. We've done all the medication management, lifestyle medication management, and it's not working. We refer them to care coordination as appropriate. Our care coordination is a team of case managers we have in the clinic that will, call the patient to create an appointment. So the care coordination will work with the patient individually on lifestyle modification, exercise, eating healthy. Also, even schedule them on going on daily walks. Sometimes these case managers, we have them schedule a meet-up points where they take on a daily 30 minutes walk. And while they're doing this, there is a goal set up for them in terms of giving them a gift card if they can achieve the blood pressure 140/90 or less, to do, to be able to motivate them to engage in this. And of course, when all these are done and knowing improvement, we also have the option of referring them to cardiologists to figure out what else is going on that's making them not to be controlled. Next slide, please. So this is the diagram that I was talking about, our hypertension care team workflow. What happens from when patient walked into the building to AMA triaging the patient, checking their blood pressures. I'm not going to go through it, but it's basically what it is I already said. But this is like snapshot of it that will guide everyone, that will help them to getting their blood pressure well controlled.
Yeah, and I just want to note that it's included in the slides, but what Sam has up right now is a PDF. So we'll share the PDF with everyone as well, so you can see some of the detail. So thanks.
Thank you. Okay, next slide, please. Okay, so what are the successes of our hypertension management from the intervention we did? So oftentimes what we know is that the provider repeating this blood pressure when they go into the room most times provides like lower blood pressure reading. And it's not because the AMAs are not doing it right. Sometimes between the time of AMA making it available for provider to come see the patient and provider going in there, patient has that time to relax, calm down. So that's what I think, helps with getting a better blood pressure reading. Another thing is, the relaxation technique I mentioned about, when the provider goes in there, try to talk with the patient, having them relax, try to assure them not to worry about anything, have them take these deep breaths, has helped to lower blood pressure in that clinic. So if in the situation where providers are not repeating the blood pressure, you tend to get high rate of uncontrolled blood pressure. While if you have taken time to repeat it, when you go in there, you notice that sometimes what we think is an uncontrolled high blood pressure is actually not. So another success is the availability of rewards with the gift card to our patients help them to stay motivated. So most of our clients, because we serve the under, most of the patients are the below poverty rate. So when they have something that financially is going to tell them, hey, you have a gift card I can use to go to grocery store. They're like, oh, well, I'm going to work my best to get my blood pressure well controlled. So we'll find out that, this gift card works. And I think we get this funding from Million Hearts. So we appreciate it and it's been helpful for our patients. Also, the fact that when you tell patient that, we're going to be referring you to cardiologists, so we're going to be referring you to care coordination. Some patients don't want that. They want to be able to come to their primary care and leave and not have to worry about going someplace else or see another person who they will consider as a stranger to them. So it motivates them to know that, okay, if I do what I need to do, take my medications every day, follow up with the lifestyle modification, my blood pressure got control, I don't have to worry myself about going to see someone else or having excess appointments in the future. Next slide, please. The challenges we've had with hypertension management for our patients is that some patients get frustrated when we're taking their blood pressure multiple times during the visits, especially when they're coming there for other stuff other than blood pressure management. They get mad and like, why am I have to do this? I just want to get my medication and go away. I just want to get my pain meds and go away. So sometimes some patients will refuse to get their blood pressure rechecked. And this is something that if I rechecked it, it might have been normal, but because they refuse, we have that high blood pressure sitting there. We don't know how to, bring it down. And sometimes they would decline not to, even get treatment in the clinic. So that's one of the challenges we have. Also, some patients not wanting to wait to recheck their blood pressure, especially for sometimes when we recheck it, the third time we decide, okay, we're going to treat you in the clinic because your blood pressure is very high to allow you to walk out here to go home. You might end up having stroke on your way home or something bad might happen. So they agreed to get treated. But what happened with that is that when we treat you, we want you to stay a little longer so we can recheck your blood pressure to see if the medication works. Some patients don't want that, and they will tell you they have other places to go, they have other better things to do. So we still end up having a high blood pressure reading sitting in the EMR without knowing whether it's controlled or not at that point. We also have some patients not wanting to be bombarded with another appointment, like I mentioned earlier. Some of them don't want to go to care coordination. They don't want to go to cardiologists because they don't have time. So this also, put up a challenge for us in terms of managing the patient's high blood pressure. That also brings us to time constraints. Some patients don't have time to come back within 2 to 4 weeks to recheck their blood pressure or to see if the medication prescribed is working. And that thing is appointment slot for patient. Even when they have the time to come in, providers might not have availability to schedule them, so they end up coming beyond 4 weeks than they're supposed to come. Also, some patients are not adherent with their self-monitoring of blood pressure. So we go through, time to give them this blood pressure machine, get them funding involved to get them the blood pressure machine. They take it home. They come back next time. Did you bring the log? No. Did you check your blood pressure? No. When last time did you check it? That first day that I went home. So it becomes challenging to actually compare what their blood pressure reading is at home and what it is in the clinic. And of course, we have many patients who don't get compliance with the lifestyle modification you educate them to. Some of them don't take the medications. They forget. Some people will come in like, oh, I was rushing out for this appointment, so I forgot to take my medication. So those are challenges we face with hypertension management. Next slide, please.
Yeah, and I appreciate this because you go through the whole same exercise where you talk about your intervention and successes and challenges with diabetes as well. So I guess we're going to share the slides with everyone, but we are a little bit under a time constraint, and I do want to allow time for questions. So please go ahead, but I think in a 2 to 3 minutes we'll try to stop for some questions. If anyone has questions in the meantime, please put them in the chat. Thank you for sharing.
Okay, yeah, I should be quick with this. For the diabetes, one of the things we do huddling with the medical assistant who identify our patients who has not had A1C level in the last 3 months. Something I didn't add there too is also a patient who have A1C level greater than 9%, which we consider uncontrolled diabetes. So with this, it makes us able to either call this patient to schedule them for appointment, either don't have appointment. And I will add that this also our QI department also provide us list of these patients like this. So we'll contact them if they don't have appointment. If they do have appointment, we know that if they come, we're going to do A1C on them. Now, the beauty of this is that we have the rapid A1C machines in the clinic. So sometimes the patients are not able to get to the lab. Either they're late to the appointment, the lab is closed. So we're able to use the A1C machine to check their hemoglobin A1C in the clinic and able to initiate proper treatment to this patient on time without waiting to get lab result from the lab company. So that helps us. We're able to refer them to nutritionists, care coordination as well come in place with this, where they also help to encourage them with their lifestyle modifications. Now, when things are not working properly, if everything is been, nutrition is not helping, care coordination is not helping, we also use the service of Soroji Health for in-depth diabetes education for these patients. They've been very vital for us and our patients. When the ones that have gone there, we've have very good positive result for our patients who have attended Soroji Health diabetes classes. Next slide, please. And also I wanted to point out in that interventions, we have the fresh food pharmacy program from our clinic where nutritionists will give them gift card to, go to pharmacy to pick up fresh fruits and vegetables to help them with their diets. The success with this is that, like I mentioned earlier, the rapid A1C testing in the clinic has helped us to provide appropriate and timely therapeutic change in our patient regimens in their medications. You also save time for our patients and prevent hassles of going to the lab for blood draw. Also, we also have gift cards available for patients, to motivate them to achieve the A1C goal of, less than 9% or 8%, depending on the patient. Next slide, please. Challenges is patients, not checking their blood pressure and blood sugar at home. Also, frustrated about getting finger sticks in the clinic. Some patients don't want to go to the appointment to care coordination or nutritionist. Also not adherent to lifestyle modification and medications as well. Next slide, please. And in summary, I would say that successful achievement of hypertension and diabetes management goals requires intervention of every medical personnel and shared decision of making with the patient. So if the patient are not cooperating, you can't achieve anything. So you have to also try to have them involved in their care, and that helps us to go a long way in getting them well controlled. Also expect challenges when you're doing this. These goals are not met in one day. It's a constant reassurance to patients, constant working with the patients and everybody involved. Thank you.
Well, thank you. You definitely flew through the end.
Thank you, I tried.
Well, but I really appreciate just your openness to both presenters to share kind of current activities. So, I mean, you're sharing metrics, you're sharing the exact process. What are some thoughts or questions from the crowd? Are you doing the same type of thing? Gift cards, looking at metrics frequently? You already heard, you'll see one of the workflows at least. Any thoughts? Oh, I'm looking in the chat. Thank you both for sharing. I know, a special thanks to the presenter, just because we know that it takes time out of a busy, busy schedule to prepare these slides and to be ready to share. It's such an open level about your initiatives. Any other questions or comments? Go ahead.
Yeah, I just wanted to comment, I'm really impressed with the level of depth that you both go through to ensure accurate data entry in the case of family medical, like really, getting accurate data from the point of contact with the patient. And then also sort of following through. I'm really interested in the MCO days and think that was just something that I hadn't really seen before. And I think that's a great thing. Can you clarify, Iswaria, in the MCO days, is the day it's a day that you're taking to schedule them, or you're putting all the appointments on that one day?
It's just like we prioritize those the patients who are under those MCOs, but then obviously we see them any other day. Like we can't assume that everybody we can't see, like, we can't assume like, oh, you have Monday, so come in on Monday. So they can come in whenever they want, but it's just like a strategy, like, hey, today is Care First Day, so since you're under this insurance, and actually even the MCOs reach out to their patients, and this is specifically targeted at people who are like not due for an exam or labs or chronic no-shows. So it's like serves as an additional reminder. And then so also that sometimes if it's a chronic no-show, we get a chance to double book our providers so that, we can make sure like our productivity stays the same. But if they want to be seen like, hey, I can't make it Monday, but I can come in on Wednesday, then that's totally fine. And we also try to keep like at least a couple slots open for patients who just want to walk in or like have like an urgent visit,
Yeah, that's great. Thank you.
Thank you. Well, and I'm glad you asked about MCOs, because I know we're at time, but a little teaser for next month. You probably remember about a year ago, we had AmeriHealth Caritas come and join and talk all about their programming. So for the next month, we have invited MedStar and AmeriHealth Caritas, and we're trying to see if AmeriGroup can join to just talk about updates given the new contracts and implementation. So if anyone has questions or suggestions for that session, please share them. We can always share those requests directly with the MCOs as we prepare. And as always, we're here to help wherever you need it. Latrice, anything else? I know we're over time, but it was a great session.
Nothing else. Thank you. Thank you, everybody.
All right. Thank you, everyone. And thanks, Sam. All right.
Thank you.
Have a good one.
Bye.